welcome to ResearchMD.com. Another great presentation. Today we've been doing a lot of lectures on endocrinology. Please make sure you go back and review it. We covered posterior pituitary. Now we're just in the anterior pituitary hormones, and we talked about the thyroid hormones, right? And we talked about hyperthyroidism. We are in the hyperthyroidism phase. So let me introduce myself. My name is Dr. Pramil Cheriyath. I'm a physician practicing in the United States, program director, internal medicine and the transitional residency. I'm an associate professor of medicine, large medical school. So let's go into our topic today. What is it? Multinodular goiter. When you talk about MNG or multinodular goiter, what is the definition? If it has to be greater than or equal to 2 nodules, then you can say multinodular goiter, okay? And then you got 2 parts. One is non-toxic and the toxic. So we got beautiful diagram over here. This is the non-toxic side and this is the toxic side. So we can compare and kind of learn from it, okay? So we're going to start with the non-toxic multinodular goiter first. And when you talk about that, the prevalence is a little bit higher, like maybe around 10 to 12%. Of course, we know it's more in females. And then clinical presentation, it could be like asymptomatic, right? And then, incidental finding, or you do a routine physical and you learn it. And if it is large goiter, of course, then we have to think about the compressive symptoms, right? You can compress on the trachea, where they can compress. Dysphagia, the esophagus, they cannot eat and all those kind of things, right? We talk about non-toxic multinodular goiter or multinodular goiter. What sign we need to know? That is called a Pemberton sign. Okay, how do you do the Pemberton sign? You bring your arms all the way around, high, and make sure the forearm touches the face, and then you can have a facial congestion, cyanosis, you start having respiratory symptoms. Usually you have to hold it there for like 1 minute. That is called the Pemberton sign, okay, because you got large goiter that's causing the thoracic outlet obstruction. When we talk about it, and then you have sudden pain in the nodule, always think there's some kind of hemorrhage into the thyroid tissues, and the laboratory exam, of course, is a non-toxic multinodular goiter, usually like pretty much no normal thyroid function, okay? And then we talk about the imaging. You can do an ultrasound, and when you do a radioactive iodine uptake, there's usually by decreased uptake. And then in large goiter, there's a compression, there's a CT, MRI, and the pulmonary function testing can be done, okay, because of the compression and all that. Now, treatment, again, it's asymptomatic, but you have to monitor yearly. You check for thyroid examination, palpate your thyroid, and check for like TSH and all that. Large goiter, then you have to think about radio iodine, and you just give the recombinant TSH also, so the iodine get into the thyroid, okay? And then you got surgery, steroid is the other option, and iodine contrast agent or iodine containing substance should be avoided. Very, very important topic. You don't want to give iodine contrast dye or iodine containing substances. What happens is you can have something called a JOD-based effect, increased thyroid hormone production, and you can go into acute thyrotoxicosis. Okay, we talked about non-toxic multinodular goiter. Now is the problem. We have to go to this side, right? Become toxic. Let's look at pathophysiology first and find out what happens over there. You have chronic iodine deficiency in these people. Goiterogens. Okay, what are goiterogens? You got some foodstuffs like cabbage, cauliflower, soyweed, and even cassava root and the sweet potatoes. That can also cause, and some of the nutrients, decrease selenium, decrease iron, decrease vitamin A, and some chemicals, dioxin, okay? And you got polychlorinated biphenyls, thiocyanate, and pesticide. They can also cause, they're called goiterogens because they can cause goiter. And then genetic susceptibility. These are the 3 things in the initial step. Then what happens is that causes decreased thyroid hormone. When there's not enough thyroid hormone, TSH has to go crazy, right? So it's going to be increased TSH. There's going to be recurrent hyperplasia, involution, and hyperplasia of the thyroid follicles. Some more active than the others. So it's going to be the nodular. Some of them active, some of them may not, okay? Development of nodules. Now, that is a pathophysiology of non-toxic multinodular goiter. Now, what happens into the toxic phase or toxic multinodular goiter, okay? Again, there's multiple somatic mutation of the TSH receptor in this group, prolonged exposure to the proliferative stimuli. Those are the 2 main things. And then autonomous functioning of the some nodules, and you got toxic multinodular goiter, and then you got hyperthyroidism, and that is this side, toxic multinodular goiter, okay? Now, let's talk about toxic multinodal goiter. It's also called a plumber's disease. Okay, and then prevalence around like up to 7%, usually greater than like 60 years of age, more in females, and then second most common cause of hyperthyroidism. What's the most common cause is usually Graves' disease. The second most common hyperthyroidism, more prevalent in the iron deficiency region. And then what are the clinical presentation? Of course, we know the hyperthyroidism. The classic hyperthyroidism features will be here. And let's comment some of the things we need to know compared to the other Graves' disease and all that. Lead lag, stare, atrial fibrillation, myopathy, fractures due to osteoporosis are very less in this group. Okay, we talk about lab examination. We know it's like hyperthyroidism, right? So what we need to know is like we need to check for TSH and free T3 for everybody, you know that, and you also check for anti-thyroid peroxidase antibodies, anti-thyroid globulin antibodies, and also you check for TSH receptor blocking antibodies, also called thyroid stimulating immunoglobulin. Okay. Now the next thing is imaging. Of course, the number one you check with an ultrasound. When you do radioactive iodine uptake, there's going to be increased uptake, or we can maybe there is, but it's going to be a patchy uptake. Okay. So when you look at the radioactive iodine uptake, remember it's a patchy uptake. And then cold nodule, you can do an FNAC. Again, when you have a compression symptom, you can do CT, MRI, pulmonary function test, because you're trying to evaluate the compression. And then treatment, you can do radioactive iodine. What are the indications for radioactive iodine? Let's look at small, medium size, benign history of thyroid surgery, irradiation to neck, advanced age, severe comorbidities, and decreased life expectancy. You go for radioactive iodine. The problem is 20% of these people may not respond. So what do we have to do? We have to go for the definite treatment, which is the thyroidectomy. Let's look at the indication for thyroidectomy: compression, malignancy, large goiter, retrosternal expansion, comorbidities include with the hyperparathyroidism requiring surgery, and then anti-thyroid medications. You have to you do pre-treat to make them euthyroid before the treatment. Okay, so let's summarize like one more time. The first thing we need to know: greater than 2 nodules, then you call it multinodular goiter. There is a non-toxic multinodular goiter. Remember about the Pemberton sign. You put your arms all the way around 180 degrees. Make sure forearm touch the face. Then you look for congestion, cyanosis, respiratory symptoms because of the thoracic outlet syndrome. Okay, and then most of this things is pretty, it's a normal thyroid function in this group. And then when you come to, pathophysiology, it's very important to know about the pathophysiology. So I'm going to go back again. Think about chronic iodine deficiency, goitrogen, genetic susceptibility, decreased thyroid hormone, increased TSH, recurrent hyperplasia, development of nodules. Then become to this side. How does it become toxic multinodular goiter? Again, genetics also has to play. Prolonged exposure to the stimuli also is there. And then you got autonomous functioning of some nodules. Then you got toxic multinodular goiter and hyperthyroidism. Then you come to the other side, you got toxic multinodular goiter. It's also called plumber's disease. And then classic signs of hyperthyroidism, and then remember, let's compare some of the symptoms like atrial fibrillation, lead lag, and that less in this people with toxic multinodular goiter. And you check your TSH, you check your free T3, T4, anti-thyroid peroxidase antibodies, anti-thyroid globulin antibodies, and of course you check the TSH receptor blocking antibodies. Okay, and then treatment: radioactive iodine. Remember, 20% may not respond, and definite treatment is for surgery. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel. Thank you.